Amazing. Well, everyone, good afternoon. We're here again with Dr. Alex, who has given us the privilege again to have him back for week 2 of his Friday Lunch and Learns. As most of you know already, he went to University of Florida, graduated in 2010, and now owns his own practice in Davie. And he's here today, back at FIU, where he graduated from as an undergrad, to give back to us. So, Dr. Alex, we're very grateful to have you here again. The floor is yours.
Thank you, Alex. Yeah, it's great to be back with you guys. Hope you guys enjoy today's lecture. So I will get my mug off the screen here. All right, and everyone is seeing the gum love slide?
Yeah.
Sweet. All right, excellent, guys. So week 2 of our 4-week dental boot camp, yeah? Just one little ground rule change from last week. I dig the questions throughout the presentation. I want this to be interactive. I want you guys to walk out, feeling like you learned stuff. But if you're gonna ask questions, my only request is that you have your video on. All right, I don't want questions coming from like the black ether of nothingness. I want a face. Cool? All right, here we go. So hashtag gum love. We're gonna talk all about gingival health today. Let's get to it, folks. Okay, maybe not. All right. So we have here, anyone know how I get rid of all this? Are you guys seeing all of this screen sharing stuff?
No, we only see.
No, we don't see it.
No? Okay, cool. So we are here, week 2, right? What bleeding gums means for your overall health and your chances of finding a mate. Weeks 3 and 4, we'll be covering COVID and TMJ. Also some other things that we're learning about the impacts in dentistry that COVID is having. So as more research comes out, I'll be updating the next lecture and adding some of the newer research. And then the last session will be undoing the damage, how we replace missing teeth. So we'll do a deep dive into partials, bridges, and implant dentistry. Just as a reminder, this is sort of like a distillation of lectures that we have in our DMD Bound program. It's a 10-week dental education program designed for pre-dental students to gain their EFDA certification and gain a whole lot of experience actually working chairside in dentistry before dental school as a ways to improve your application, become a stronger applicant to dental school, develop your hand skills, and learn dentistry. All righty, so healthy gums means a healthy you. It is a very, very common condition, right? Periodontal disease is a chronic, super important to understand, it's a chronic bacterial infection of the gums, and it affects over 50% of the US adult population. Over 50%. That means that half of you guys, which are part of the US adult population, statistically will have some degree of periodontal disease. Those estimates vary a little bit. Some studies show that it's as high as 70% of the US adult population, but 50% is a very conservative number. All right. Now, COVID has had, we're going to touch on COVID a little bit here today, has also had a huge impact on what we're seeing clinically with regards to gingival health. Now, mask mouth is real, folks. Very, very real, okay? When we're wearing these masks all day, every day, several things happen. One, we hydrate less. So the mouth just naturally becomes this pastier environment, right? Not great for our overall health. Other thing that happens is some studies are starting to show that the actual bacterial population in that environment starts to change and becomes more pathologic, right? So what we're seeing clinically is that folks that had periodontal disease that was fairly well controlled are having spikes. And all of a sudden we're seeing flare-ups of gum disease and other things that we really have nothing else to point at other than COVID, its impacts, how it's changing our daily life, right? Wearing the masks all the time. It's also probably led to some awkward dating moments. I don't know, does that look about right to anyone?
Yes, it's very accurate.
So, how to not make a good first impression. All right, when that mask comes off, folks, don't underestimate the power of the funk. All right, so periodontal disease, gum disease in general, right? Either gingivitis or periodontitis, bacterial infection of the gums, right? Number one cause for chronic bad breath. Now, 50% of the US adult population has some degree of that gum disease, right? Tack on top of that mask, that pasty environment. And folks, when that mask comes off, like, it'll melt metal, right? So just be aware, okay? Don't shoot yourself in the foot on the first day when you pop that mask off. Another reason to floss like your dating life depends on it. All right, the cleaner and the healthier we keep things, the more we're controlling that bacterial infection, the less offensive our breath becomes. All right, so let's get into the meat and potatoes of what we're doing here today. We're going to be talking about two broad categories of gingival health. So first, gum health itself, what it means and why it matters, right? And the second part of our talk today is going to be about pink aesthetics, right? In smile design, in cosmetic dentistry, like oftentimes people, and some dentists too, focus solely on what we call white aesthetics, right? White, where are the teeth? What's the shape of the teeth? What's the shade of the teeth? What's the position of the teeth? All about the teeth. But that's just part of the story, right? The gums and the lips make up the smile too. So as smile designers, right, folks, dentists who like cosmetic dentistry, we have to bear in mind the impact that gums have on the overall end result too. And we'll talk a little bit about what that means, how we go about it, how we assess it. Okay, I told you guys last week that you would be seeing this diagram again. We need to know it like the back of our hands, folks. All right, so let's go through it one more time. On the left side, we have the top is the crown of the tooth, right? The crown of the tooth is the part of the tooth that we see, the part that's extending above the gum line. Beneath that, we have the root. That's the part of the tooth that's embedded in bone that we cannot see. It's what gives the tooth stability. Now, in a healthy tooth, in a healthy mouth, we want to see about a 2-to-1 root to crown ratio. We want to have about twice the length of root compared to height of crown. All right, that's going to give us a tooth that can withstand the rigors and pressure of chewing and functioning well. On the right side, we have the layers of the tooth. All right, those of you that were with us last week, remember the peanut M&M analogy, right? We got our candy coating shell on the outside. That's the enamel of the tooth. That's the protective layer. We have chocolate underneath that. That is the dentin. And then we have the peanut, which is the pulp. And in the pulp is where all the magic happens, right? That's where we have the nerves. That's where we have the blood vessels that go to the tooth. Blood vessels. Nerve. Around the tooth, we have the gums, right? Technical term being the gingiva. Now, the protective layer of the crown of the tooth is the enamel. But if we extend down from the enamel to the root, that protective layer becomes something called cementum. And the interface where these two guys meet is called the cemento-enamel junction. All right, and that's a very important term in dentistry. As dentists, we love, for some reason, we love junctions. Like where two things come together, we can't wait to put a label on it. in the case of the anatomy of the tooth here, where the enamel meets the cementum, CEJ, cemento-enamel junction, it's a very important landmark to track how healthy our patient's bone levels are, because this never moves. As periodontal disease progresses, we may start to lose bone, but we always have this as a reference point. So we can always measure against that CEJ to see how well that bone is doing over time. All right, so CEJ, very important landmark. Now, around the roots, we have the periodontal ligament, or the PDL, and it's almost like a little shock absorber between the tooth and the bone around it. Right? It acts as a shock absorber and also like a layer of Velcro, sort of holding the tooth in place. Now, towards the end of the roots here, as the nerve starts to exit the tooth, we have all of these little lateral canals or accessory canals. And it's just smaller versions of this main canal coming down the middle of the root. All right, so without a doubt, guys, we will be seeing this diagram over and over and over. And by the end of this boot camp, this will be like second nature to you guys. Going to take a brief detour from the talk here to introduce you to an instrument that is indispensable to the whole gingival health conversation, the periodontal ruler. All right, this is commonly, most frequently called a perio probe, but I have banned the word probe from my practice because it elicits thoughts of what aliens do when they abduct people, right? We don't want any of that. So we don't want to be probing people's mouths. That just sounds awful. So we call it a ruler. We call it a gum ruler. And the gum ruler has all these little markings, right? And these markings correspond to millimeters. So we have 1, 2, 3 millimeters. Then the most commonly used rulers skip to 5 millimeters, then 7, 8, 9, 10. And this is used to measure the pockets. Okay, so where the gums meet the tooth, we all have a little space called a pocket. All right. The technical term is a sulcus, but we all call it pockets, and we refer to them as pockets for our patients because it's just easier to wrap your head around it. Now, a healthy pocket is either 1, 2, or 3 millimeters deep, and it doesn't bleed when we measure it. All right, when we stick our ruler in there to see how healthy that gum tissue is, it can go down around 3 millimeters, but the tissue is nice and firm and healthy and pink, and you can put that ruler in there and take it out and nothing happens. But if we have gum disease, really to any extent, that pocket gets deeper, the gums get swollen, and when you insert that ruler and take it out, you get this little gush of blood. All right? And what that's telling you is that there's inflammation in those gums and they're not healthy. How unhealthy, we don't know that yet, right? But it gives us an idea that that is a potential problem area. Now, patients frequently say, and some of you guys may be thinking, well, if I jab that quote unquote ruler that looks like a sharp pointy thing into someone's gums, how are they not gonna bleed? Right? Of course they're gonna bleed. Well, no, not at all. They won't bleed if the gums are healthy. Because think about it. Your gums are designed to take a beating, right? Think of the things that we eat: Doritos, tortilla chips, nuts, anything crunchy, right? If the gums couldn't take that beating, every time you went through a bag of Doritos, you'd just be like pouring blood out of your mouth, right? So in the mouth, we have two different kinds of tissue. The gingiva, or the tissue around our teeth, like right up against the teeth, it's like the palm of your hand. It's a very thick tissue designed to take a beating and be very resilient. So unless, I mean, if you washed your hands and they started to bleed, that would be an issue, right? You would know there's something wrong with your hands. Same thing with the gums, right? We can measure them, we can eat things, we should be able to brush and floss and no bleeding happening. If there's bleeding, we know there's disease. Okay? So, early disease. Early disease is shallower disease, right? So that pocket now, when it was healthy, it was no more than 3 millimeters. So we start having some inflammation of the gums. Now that pocket is maybe not 3 millimeters, but it's 4 or 5. And when we insert the ruler and take it out, we have some bleeding happening. All right. So we call this disease gingivitis. Everyone's heard of gingivitis, right? Gingivitis means, right, we all remember from the last lecture, itis means inflammation. We know gingiva is the gums, so it's inflammation of the gums. Cool? The big thing to note here is that that infection has not started to affect the bone yet. All right, that infection is just limited to the soft tissue around the teeth. But if we don't do something about it, that infection gets deeper, right? And it goes from 3 to 4 to maybe 5 millimeters deep. And now the infection is close enough that it starts affecting the bone. So look at the bone up here, really close to the CEJ. All right, this is a nice example of the CEJ. The enamel is white, and you can see a line here as we transition to the root. This is cementum. This is enamel. This line here is the CEJ, right? So the bone is usually really close to that CEJ level. Now that bone's starting to break down, right? CEJ still up here, the bone's all the way down here. And we really start affecting that 2-to-1 ratio, right, that we want to see. So this is more advanced disease, more advanced gum disease. And it continues to progress and progress and progress and progress until it eats away all the bone around teeth and they become floppy and they fall out. This is the #1 reason people lose teeth, even today. And it's a condition we call periodontitis. I'm a big root word guy. Like, I love breaking things down and understanding what the components of all these terms are. So periodontitis. Itis, we know, inflammation, right? When it's gingivitis, it means the inflammation is just localized to the gums. Now, perio means around, right? Root word of periphery, right? It's around, dont, teeth. So it's inflammation around the teeth, okay? And that is what we call it when it starts affecting the bone and we start eating away at the bone. Now, we're going to do a little bit more science here now, all right? A little bit of micro. I'm sure you guys are thrilled about that. Now, there is a very fascinating thing that happens. As the pocket gets deeper, the environment in that pocket changes, right? So when we have a nice shallow pocket, like 1 to 3 millimeters, we have certain kinds of bacteria there. All right, we have AA, we have the green complex, and what's called orange associated complex. We'll call them yellow complex, right? So green and yellow, good, red, bad, right? So when we have a nice shallow pocket, that is a more aerobic environment. Who can help me out? Aerobic, what does that mean?
There's oxygen present.
Oxygen's present, exactly, right? So the kind of bacteria that live in that environment are different than the kind of bacteria that live in an anaerobic environment or an environment where there is no oxygen. And that's what we start to see as the pocket gets deeper, right? It just sort of makes sense, right? The deeper this tight space is, the less communication with where the oxygen is, which is on the outside, you're going to have. So the environment becomes anaerobic. And as that transition from aerobic to anaerobic happens, the bugs change and they become more damaging, right? So by the time you have a 5 millimeter pocket, the kinds of bacteria that you have in there aren't the same as they were when you had a 3 millimeter pocket. they do a lot more damage a lot faster. So if we put all these pieces together, right, you can see how it's easier to manage things when we're here, right? And it's going to take a while for the damage to happen to get us deeper and deeper and deeper. But man, it snowballs, right? Once we start seeing that bone loss and that deeper pocketing in patients, if we don't intervene quickly, it goes downhill really, really fast. Any questions about this?
I have
I
a
have a
question.
question. Oh, go ahead.
Oh, thank you. So when we have a patient that presents with, let's say, a 5 mm, and we start to go on like a reversal process, right? How does the patient just have to manage their mouth extra because there's no way to regenerate that bone or those ligaments, correct?
Yes and no. That's a great question, Mercedes. So I always tell patients, you do the heavy lifting, right, in managing this process. And it is a very, very difficult process to manage. It used to be, right, for our parents' generation, being diagnosed with periodontal disease was basically being told you're going to lose a bunch of teeth, right? Nowadays, we're able to much more effectively manage that disease process. And we're going to kind of go into, I think we're going to answer your question as we go along here, because we're going to go into the different tools in our toolbox, right, to help patients manage the situation. But without a doubt, once we start getting into like a 5 mm pocket, it becomes very, very difficult to manage the situation and keep patients healthy. We'll definitely get to how we manage all this. Okay. So here we have kind of like a diagram of an X-ray, right? And the disease progression. Now, regarding periodontitis, right, or periodontal disease, 3 things that are very important to know. It is irreversible, it is incurable, and it is transmissible. Okay? So, irreversible. The damage that is done to the bone is done. It is a very hot topic of contention in dentistry still, whether or not we can regenerate bone predictably for periodontal patients. There are some procedures, some approaches out there that have shown some promise, but not all the time. So the predictable part is still very much debated. Okay? It's incurable. That we know for sure. We can manage periodontal disease, but we don't cure it. It's kind of like diabetes, right? When you have diabetes, you can live a perfectly healthy life, but you are managing that condition forever, right? Periodontal disease is no different. If we catch it early, we can manage it great, but we're going to be managing it forever. The third thing, transmissible, right? So these are bugs. If you share a spoon with someone who has periodontal disease, you are getting some of those bugs in your mouth. Ew. Okay, so it's not as simple as that, right? Nothing in medicine is as simple as sharing a spoon and you have periodontal disease, right? We need to be susceptible to disease in order to develop the disease. All right, so some folks are genetically more susceptible to periodontal disease, and simply sharing a spoon once may, give them the right mix of bugs to develop the gum disease, but for some people, not so much. So we're not really going to get into the depths of the transmissibility component, but it very much is transmissible. So yeah, be careful where you share spoons. Now, here we have, again, you guys sort of pick this out in the other diagrams. On the left side, this is where we want our bone to be, right? Who can chime in where the enamel ends here and the covering layer of the root starts? What is this transition here called?
CEJ.
EJ.
Beautiful.
Cemento enamel junction.
Oh, all right. We have an overachiever with the whole thing. Beautiful. Yes, the cemento enamel junction. Perfect. All right. So another very important thing to note. All of the bone in our body, imagine it to be structured like an orange. Okay? It's not spherical, right? But work with me here. The bone in our body has an outer layer, kind of like the rind of the orange, called the cortex, right? And just like the orange has that hard outer protective layer and the inside is kind of soft and mushy, same thing happens with the bone, folks. Like bone is not like granite where it's solid through and through. All right, bone is really, really hard on the outside and really kind of mushy and soft on the inside. All right, you can basically scoop it out. Okay, so we know that this periodontal disease eats away at the bone, right? And it takes a long time for it to get started. And once it does, it really speeds up and kind of snowballs. So let's think through that. Why is that? So this infection, right? So here we have the rind, we call the cortex, right? And then inside we have the inside of the orange, that's medullary bone, right? That's soft stuff there. So the first part of bone that infection has to eat through is all orange rind. It's really thick, hard bone. It takes a long time to break that down. But once you do, right, and you're into that fleshy bone, guess what happens? That bone just grows that much faster. And as it progresses, right, the surface area that's exposed of that soft bone grows. So you guys can see how it all sort of snowballs, right, and speeds up. Not only is the pocket getting deeper and the bugs getting more aggressive, they're harder to clean out regularly, and the bone that we're breaking down is softer, right? Everything just sort of comes together to really present a bad picture. And on this diagram, we have these little growths here, right? We will frequently see these on x-rays. Anybody care to chime in as to what those are? Awesome. So those are tartar deposits. Okay. So tartar is the layman's term for what we in dentistry call calculus, right? And it sucks just as much as the arithmetic. Okay. So what calculus is plaque and bacteria that has sat on our teeth long enough to literally create a shell around it out of the minerals in our saliva and become rock hard. It's like barnacles growing on the side of a boat. And those colonies of tartar, those colonies of bacteria are constantly just kicking out the toxins to make this process move along, right? Just make more and more and more toxins and break down that bone more and more and keep the area inflamed and bleeding and unhealthy. Not so good. All right, so we divvy up periodontal disease into stages 1 through 4. In stage 1, we have up to about 15% bone loss. Stage 2, up to 1/3 of the bone is lost. Stage 3, up to 50, and then stage 4, more than 50% of the bone has been lost. All right, so if we go back to this diagram here we're on stage 1. Here, maybe, I don't know, somewhere between stage 1 and stage 2. Like these sorts of things, like we'll put a label on it, but it's not that cut and dry, right? Like it may be stage 2 on this side and a stage 1 on this side, right? It's kind of like a lot of gray areas there, and it's just a general classification system that we have. But you guys can see, like here, we've probably lost about 50% of the bone, right? So now in a situation like this, that 2-to-1 root to crown ratio that we want to have, we've inverted that. Guys.
Hey,
Hello.
Okay. Sorry about that, y'all. Thank you, Comcast. All right, so we're back here. Everyone can see where you guys are seeing me now. So let's go ahead and change that. All right, so you guys are seeing the stages?
Yes.
Cool.
Yes.
All right, so I'm not sure where we left off. Did you guys hear me talk about this?
Yeah, you said that
Yes.
they were sort of generalized, like they're not exact percentages.
Okay. Yeah, it's sort of like a gray art, staging and categorizing periodontal disease. So stages 1 through 4, right? By the time we hit stage 4, we've got quite a bit of bone loss. And did you guys hear the part where at this point we've inverted that crown to root ratio?
Yes.
Yeah.
That's
Okay.
Yeah, you said.
Cool.
Yeah.
All righty. So another super duper important thing to realize and understand about periodontal disease is the oral systemic link. Okay. This is a huge topic in dentistry. And what it means is the connection between the mouth and the rest of the body. Forever in modern medicine, and we are probably to blame as dentists, there has been this disconnect between the mouth and the rest of the body. And it's baffling. Like, why does that disconnect exist? Right? We are super territorial about the mouth, and we've kept it the black box, right, from physicians out there, which are our frenemies for some weird reason. And to the point where my wife's a pediatrician, right? She also went to UF, and we talk about it all the time about this disconnect. You know how much physicians get on like mouth training at all in med school? They get like a lecture, right? Crazy. In any case, it has taken science and research a long time to catch up on what this oral systemic link means because of that reason, because there's been that disconnect between the two fields for so long. But we're starting to bridge that gap. And we're starting to learn more and more research is coming out every single day as to what it means to our overall systemic health to have oral disease, all right? And specifically, when we're talking about periodontal disease, we know that in the presence of periodontal disease, we are at a higher risk for conditions like heart attack and stroke, Alzheimer's, cancer, diabetes, things like early term birth that have periodontal disease, right? So it is not just this condition that is affecting the mouth and causing us to potentially lose our teeth. It is putting our lives at risk, right? And the lives of our loved ones. Now, why? How? What's the connection? I think I lost you guys again.
You're freezing in and out, but we can hear you.
You can hear me.
Okay. All right. So what is the connection?
Is it bacteria?
How does it happen? We're talking about pockets, right? As those pockets get deeper, the kinds of bacteria start changing, and we have more and more virulent pathogens in there. And what do you think happens when that patient that has that 6 millimeter pocket that's bleeding all the time? What do you think happens to that bacteria when the gums in that area bleed? Like, why do the gums bleed? Right? They bleed because some capillary broke, right? Like, that's how we get the bleeding. And the moment that capillary opens, bacteria can rush into the capillary and now join the bloodstream and get carried all throughout the body. And there are specific bugs that live in those deep pockets, things called spirochetes. And when they go to the brain, like we see those periodontic bacteria in Alzheimer's patients' brains, right, as one of the contributing factors to, if not giving them, like no one's saying that if you have periodontal disease, you're going to get Alzheimer's, right? Like, that's not how medicine works. All right. It's all of these different factors that have to come together to get us to that endpoint, right? But it is one of the factors. right? And it rests on us to educate our patients on those factors and give them tools to minimize those risk factors, right? So the oral systemic link, very, very, very important. So the bacteria gets into the bloodstream, rushes all around, creates all of these pro-inflammatory responses. That taxes our entire body, right? Our immune system is almost like a battery, right? And you start draining that battery with infections and things that that battery needs to fight, right? Our immune system's an army. We can only deploy it in so many places and be effective, right? If we have a chronic infection in the mouth, like that army's constantly fighting that, not as able to fight other things, including, interestingly enough, COVID. In the presence of active periodontal disease, we are at a higher risk for contracting COVID for the simple fact that our immune system is not as capable to fight off that infection, that initial insult. So it is not just what is happening in the mouth. All right, so what are risk factors, right? Because we talked a little bit earlier, it's not just you share the spoon, you get the bugs, boom, you've got periodontal disease, then boom, you've got COVID and you're in the ICU. And it doesn't work like that, right? We have all of these different risk factors. So let's take a look at it. We have systemic conditions, right? Autoimmune diseases, right? People that just naturally aren't able to fight off infections. Folks with diabetes, right? We know that people with diabetes have a higher propensity for periodontal disease, and people with periodontal disease have a much more difficult time managing their diabetes. A very strong relationship between those two. Things like lifestyle, smoking, and vaping put us at a higher risk for periodontal disease. And does anybody know why smoking puts us at a higher risk for periodontal disease? There's two reasons. Go ahead.
Maybe less blood supply towards the mouth.
Beautiful. That's one. And what causes that less blood supply?
The nicotine?
The blood.
Yes, very good.
But that's beautiful.
The nicotine. It's the nicotine that does the damage to the gum tissue, right? What's the other thing? So we've got loss of blood supply from the nicotine. What's the other big impact? What was that?
I was going to say dry mouth.
Yes, exactly. Dry mouth. So we talked about it last week with decay and how impactful it is for the bacteria, right? It's the same thing with periodontal disease. It's also bacteria. They're also making acid, okay? So if you cut the blood flow, which is what bringing in nutrients to keep things healthy, and you make the environment drier, right? So that now we're not combating the effects of the bacteria as much. Those two together are cause a really big impact, right? They bear a lot of weight. And then the third risk factor is biofilm removal, right? So when bacteria sits in our mouth, they create a sticky, slimy layer called biofilm. That's why we brush and floss, people. It's to scrape that biofilm off of our teeth. And we also have things like water picks, proxy brushes, all sorts of different tools to remove biofilm. All right, so brushing, flossing, water picking, huge fan of water picks. A large percentage of my patients use water picks, and we use like medicated mouthwashes in the water pick so that they can irrigate those pockets, flush them out, kill bacteria. Like we said, the heavy lifting is done by our patients, right? They are in control of the at-home care, which is 99% of the therapy they're getting on a regular basis. They come to see us at most like once every 3 months, right? The other 90 days, it's all them. So we have to be able to share with them the proper tools that they need, and not only tell them what tool to get, but teach them how to use it effectively, right? It is surprising how many of us don't know how to brush our teeth? Period. And if there's one thing that we can do to impact people's like overall oral health and lifelong relationship with dentistry, is how to teach them to effectively brush their teeth. All right. We're not going to get into that today, but it's really, really important. And it's just one of those things that gets frequently overlooked because we're busy in the practice and we got to run into the next room and do that root canal or that implant, right? And spending 5 minutes with Mrs. Jones teaching her how to brush and floss her teeth, just sometimes you don't have the time. But man, it is one of the most important things that we do. Now, you guys saw this diagram last week, right? We were talking about tooth surfaces. We have 5 surfaces in our teeth, right? We have occlusal, or the chewing surface. We have lingual, or the tongue side. We have buccal, or the outside, cheek or lip side. Then we have the mesial, which means it moves towards the midline. And the distal part of the tooth is the one facing the rear, towards the back. All right. So we were talking last time about how important it was to floss for decay prevention. Because if you do a 100% job just brushing, that means that you're going to get 3 of these 5 sides, right? The brush will reach buccal, occlusal, and lingual. But as far as distal and mesial goes, you're out of luck. You're not getting floss in there. You're not cleaning it. Same thing with gum disease, right? The biofilm removal process is the same for decay and gum disease. And for the exact same reason, if we're not flossing, the gums in here just aren't getting cleaned. So it's no surprise that 99% of the periodontal disease that we see is interproximal, meaning between teeth, right? This is where we lose the majority of the bone. We don't lose so much bone here. We lose a ton of bone here in between the teeth, right? So we were talking about, all right, so what do we do to manage this situation? I'm going to back up a little bit. Let's see. No, there's nothing there. Okay. So we're brushing. All right, we'll take a look at this cross section here. We have the tooth. We have the gums. We have the bone. We have our sulcus, or the pocket, right? This is where the fight happens. So brushing and flossing, indispensable tools. Anybody care to guess how deep into a pocket brushing and flossing reaches? Just throw out a number.
2 millimeters.
What was that? 2?
Yeah, 2.
Ding, ding, ding. 2 millimeters. So let's think about this for a second. Brushing and flossing to prevent gum disease, to keep our gums healthy. We have these pockets all around every one of our teeth, right? Where a healthy range of pocket is 1 to 3 millimeters. So if your gums are totally healthy and nothing is over a 3 and nothing's bleeding, and you brush and you floss and you do 100% job brushing and flossing, which no one ever does, that still means that the deepest part of that well, the deepest part of that pocket, you're not touching, right? There's bacteria living in there that we can't reach. We can't clean out with brushing and flossing alone. Okay. So why doesn't everything go downhill immediately, right? We have bacteria in there. It should just start eating away the bone like the moment we grow teeth. Well, nothing's that clean, right, in medicine, right? So the what happens is that if you remove the majority of the bacteria, your body can fight off the rest, right? You're still maintaining a balance there, a healthy environment where your body's immune system can do its job and keep you healthy. All right. As soon as we throw that balance out of whack, it's all downhill. Okay. So let's talk about what happens when we start getting deeper pockets, right? Let's say we have a 4 or 5 millimeter pocket. What do we do? Like, what tools do we give our patients to do that 99% of the therapy that they need to do when they're at home, right? How do they reach that 6 millimeter pocket? And heaven forbid it's a 7 or 8 millimeter pocket. What do we do? This has been a transformative element in my practice. It's a system called PerioProtect. I have never felt, until I incorporated this into the practice, that I was able to give my periodontal patients any sort of effective at-home protocol. Now, what this does, now, it's simply a hydrogen peroxide treatment, right? We make these custom trays that have this little well here. They have a patented design, and we put a peroxide gel in that tray, and we have them put on the trays. Now, hydrogen peroxide kills bacteria, right? If you get a cut on your arm, you put some hydrogen peroxide there and it's clean. Well, when you're talking about a 7, 8 millimeter pocket, you can't just swish with hydrogen peroxide, because guess what? Whereas the brush reaches 2 millimeters, Listerine mouthwash reaches a 0.5 millimeter below the gum line. Okay? So unless you're using some other means of delivering that medicine to that deep part of the pocket where you need it, it's not going to get there. Right? One of the tools that we have is the water pick. Right? We can put some medicated mouthwash, have the patient water pick, sort of aiming the jet into that sulcus there. And that's going to provide some debridement, right? Some irrigation of the area. But that's like the blink of an eye, right? Like they're just water picking, just going around all the teeth. You can imagine, like if you have a whole bunch of bacteria here, you're going to have to water pick for like 6.5 years before you actually cure anything, right? Fix anything, right? So what we do with this hydrogen peroxide, you pop the trays on and it forces that hydrogen peroxide into the sulcus and holds it there for 15 minutes at a time. And this gel is like specially formulated, so it doesn't explode the way normal hydrogen peroxide does, right? You pour it on your arm, you have a cut, it like foams up really quick. Yeah. So this stuff works different. It's like an extended release. So for those 15 minutes, it's just bubbling, and killing bacteria. And depending on the extent of the periodontal disease, like we'll have treatment phases for patients to use this 3 or even 4 times a day. And then as the gums get healthy, they can taper it down to eventually do it once a day as like supportive therapy at home. And guys, it is transformative, right? The results that we're seeing for our patients is just unbelievable. Oh, and the cherry on top, it's hydrogen peroxide, so it whitens your teeth, right? So it keeps them super motivated to keep doing it because their smile stays nice and bright and their breath doesn't stink, right? So, dude, win, right? Amazing. Okay, another thing that we do a lot of is laser therapy, right? Lasers, come on, lasers are cool, right? Everyone wants to play with a laser, right? Who has it? Dr. Evil said it best. Yeah, lasers. So lasers allow us to decontaminate pockets, all right? The most commonly used laser in dentistry is something called a diode laser, and that's what we're looking at here. And laser, really all a laser does is it focuses light, right? It focuses light to create a lot of energy, right? A lot of heat. And we use those laser tips to go around the pockets and kill the bacteria that's living in the pocket. Okay? So clearly we're not going to send a patient home with a laser and be like, Mrs. Jones, I want you to 3 times a day, please laser your pockets. That would not end well. But we do it in the office, right? We do that in combination with things like deep cleanings or periodontal maintenance cleanings and things like that. Because one thing that is really important to note, that I went back a slide here, right? You guys are seeing the PerioProtect slide again? So bacteria is living here, right? And this is a solid surface that it's growing on, right? Here we have the enamel and here we have the, I didn't freeze, I'm waiting for the word.
PE junction.
Well, what's the layer of
Cementum.
The cementum? That's right. But here we have soft tissue, right? So this bacteria isn't just living in this pocket isolated from what's going on around it. It penetrates the tissue and infects the tissue, right? So with the laser, we're literally removing that layer of diseased tissue, right? We're killing bacteria, removing diseased tissue, and now the whole area has a better shot of bouncing back. And your immune system is going to have a better shot of bouncing back and controlling that infection. Another thing that we like to do is salivary diagnostics. Literally have patients spit in a cup, put it under a microscope, and see what time it is. All right. What bacteria are we dealing with? Is it orange complex? Is it red complex? Is it a mix of the two? Is there a fungal component? Right? What are the bugs? Because if all of this other stuff doesn't really work, we start targeting and making custom antibiotic cocktails for people, right? To target the different kind of bacteria that they have, right? This is what the company that I work with is called Oral DNA. They're great. They send back this report showing us, all right, so here we have AA, which is a very common bug, and red complex. Here we have orange complex, green complex bacteria. What do we have? What's elevated above the threshold where we know that we need to intervene and do something about it? And just really gives us a roadmap, right? So we'll usually use this with patients that have really, really hard periodontal disease to manage. And we'll usually do it before and after our treatments, right? Let's see how that bacterial population changed and evolved, right? Really, really effective stuff. Okay, so here we're going to go to the second part of the lecture. We're going to talk about a little bit about aesthetics, pink aesthetics, gum aesthetics. Now, there are three main components to pink aesthetics. There's health, exposure, and architecture. All right, we're going to talk a little bit about this. The first one is obvious, right? Pink is pretty. Healthy gums are nice and pale pink, right? If we had a bunch of swelling and inflammation around these teeth, doesn't matter how straight her smile is, she is not going to have an attractive smile, right? So it's not just about straight white teeth. It's about nice pale pink, pretty gums too. Mm-hmm. All right, so yeah, just gonna let you guys bask in that for a second. Take all that in. Let's break this down. Let's see what's going on here. So first thing that jumps out at us is that the teeth look, it looks jacked, right? Let's just be honest. But the teeth are coated, right? They look grainy. So this is all biofilm, right? This is all plaque and bacteria. That is all that sticky, slimy layer. It literally looks slimy right in between these two teeth. Who can tell me what tooth numbers these are?
8 and 9.
Okay. No. Good guess. 8 and 9 are the maxillary central incisors. All right. The mandibular central incisors, we have 24 and 25. All right. So when we count teeth, we start on the upper right, wisdom tooth, which is number 1, which would be all the way back here. And we would go around this way, 1 through 16. Then we would drop down here to number 17 and come this way down to number 32. So that makes this guy 24 and this guy 25. And between 24 and 25, it literally looks like a slug. So we have all this biofilm built up and we have a massive amount of inflammation, right? Look at this, right? Like it is so inflamed, it's grown babies, like inflammation babies here. Clearly not a healthy presentation. This is her 6 months later. From this to that. That is dramatic, folks. Very, very dramatic. She has a lot of recession here on the canines. You can see it here. You can see where that gum line is. But look at the amount of plaque and bacteria built up in that well around those gums. Look at that. Right? So between coaching and advice that we were able to give her and some treatment that we did and her radically improved at-home therapy and at-home care, she got herself to this point here. Right? I would attribute the majority of success of this case to that 5-minute conversation on how to brush and floss and why it matters. And this young lady's life is forever changed. She came into this appointment a different person. She didn't want to smile when she first came in, right? She would barely look you in the eye. And an oral hygiene conversation, folks, was the most transformative aspect of her. I mean, I get goosebumps and I get a little bit choked up when I talk about it because her career blossomed after this. She got a promotion. Like, it changes people's lives, man. It's not just teeth and gums, right? Like, we are, as dentists, we are quality of life doctors, right? Very little of what we do saves people's lives, right? Like, managing your periodontal disease will cut down the risk of things like Alzheimer's and things like that, right? No doubt those links are important and we need to know about those things. If you have a really bad dental abscess, you could die from that. But those are rare things, guys. The impact that we have on people's quality of life, their ability to smile and chew and feel good about themselves is massive. And that matters. So again, floss, like your dating life depends on it, because she was in a lot better place on that front there than she was there. Okay, the next point on Pink Aesthetics is exposure, tissue exposure, gummy smiles, right? Everyone's heard the term gummy smile, right? What the layman interprets as a gummy smile is more than 3 millimeters of gum exposure when you smile. 3 millimeters. That is not a lot. It's about 1/10 of an inch, right? So the average person, when asked, would describe this as a gummy smile, right? And it has to do with, in dentistry, we call it lip line. Where is the line your upper lip creates when you're smiling fully? So we have a high, a moderate, and a low lip line on smiling. The consensus as far as how much gum to show for an ideally aesthetic smile is, yes, less than 3 millimeters, but right around here, right? You're showing papilla, or the little pink triangle between the teeth, but that's kind of about it. So what do? Right? We're smile designers, and we have someone come in and we're assessing all of these different things, and they have a super high lip line. Like, they're super cheery and they have a great friendly smile, but when they smile, man, it's like you can see everything up there, right? What do you do? Well, we have options. Option number 1, my first recommendation: practice your smile. Hollywood stars sit in front of a mirror and they have people coaching them on how to smile. And it's a muscle, and it's muscle memory. And you do it enough times in front of the mirror, and the next time someone pulls out their phone to take a selfie, it's like, boom, muscle memory. I know how to smile the right way, right? And it's really, really interesting to me watching this on Zoom, because I'm seeing y'all's faces and people are holding back on smiling on this because, like, I don't know if my lip line's too high. right? I need to sit in front of a mirror and smile, practice. But it's super effective, guys. And it's super duper effective. It is one of those things where people don't even think about practicing their smile, right? And you just sit in front of a mirror a couple times for a few minutes and you will it's almost like you make the new connections on how to smile and it becomes your new normal, right? Now, if that doesn't work, we have Botox. Now, Botox is how we medically manage muscle behavior. Okay? Everyone's heard about Botox for wrinkles and this, that, and the other, and plastics and whatever, right? But what is Botox doing? Now, the only reason, so let's take the forehead, for instance, right? People inject Botox in the forehead because they have these horizontal wrinkles on their forehead. The reason those wrinkles are there, those wrinkles are creases in the skin, it's because the muscle flexes, all right, raises your eyebrows and crinkles the forehead, right? And if we do that over and over and over and over and over and over and over again, you end up with those wrinkles, those horizontal lines on the forehead. So what do? We inject some Botox, right? And what the Botox does is it relaxes the muscle for a few months. And if the muscle can't contract, the skin can't wrinkle. So Botox isn't doing anything to the skin. Zero effect on the skin. You're not making more collagen. The wrinkle isn't going away. It's just preventing the muscle from crinkling the skin over and over again. And it sort of stretches out and smooths, right? So we use Botox for other aesthetic reasons. Now, for a gummy smile, right, everything is controlled by muscles. There are 3 primary muscles that lift the lip when we're smiling. And they are the levator labii superioris, aliquid nasi, which is just really fun to say, the levator labii superioris, and the zygomaticus minor, right? And it's this guy, and that guy there, right? So those muscles run vertically, right? So when that muscle contracts, it's lifting the lip up, okay? We have other muscles that control the smile, right? Because the upper lip doesn't just go straight up when you smile, right? It widens, right? So we have the zygomaticus major, the buccinator plays a role, all of these other muscles that are attached to the lips. It's almost like a choreography. As those muscles contract, your upper lip expands, rises, you show your upper front teeth, and now you're friendly. Right? That's all that's happening. This is all like caveman communication stuff. Okay? So what we do, we never want to hit the muscles that widen the smile. Right? Because if you miss with your Botox and now the person's smile can't widen, right, or lift, like now they're not going to be able to convey friendliness at all. But if we're very careful and we put the medicine right where it needs to go, which is where those 3 muscles meet right next to the nose, it'll weaken them just enough so that the upper lip can't go up as high, right? And they shouldn't lose any function of the smile widening, but they'll lose just a little bit of that upper lip rising up. Here we have a case that we did a while back. This was her right before, right? Pretty gummy smile. This was her after the Botox. So Botox isn't immediate. It takes about 7 days to do its thing. So the patient walks out really looking the same. But then at their refinement visit, we always bring them back a week or so later, see how things went, see if we need to apply more. You better not have applied too much the first go around because you can't take it out. But see what kind of results they got. And she was stoked. She was super duper happy. And third, the architecture, right? Architecture has to do with balance and distribution, okay? So even for the novice smile critic, symmetry is very important. We are trained to identify symmetry as pretty. So if things to us look the same on the left and the right of the midline, that's a good thing. And something that we see very, very frequently when we start analyzing smiles now at a more critical level, and don't be mean critical, but use the tools that you have and the knowledge you have to assess smiles, is lack of balance. So things like this here, where numbers 8 and 9 have a different height of the gum tissue, right? That's not aesthetic. So we have this case here. Now, this is kind of like the reverse of the diagram that you just saw. Tooth number 8 is significantly shorter than tooth number 9. And what we do is a procedure called a gingivoplasty. So you guys may have heard of rhinoplasty, right, for a nose job, right? So there we're reshaping the nose. Here we're reshaping the gingiva. It's a gingivoplasty. And we can do that with either a laser or a scalpel. And this is, I use a laser to do the procedure. This is immediately post-op, right? So the beauty of the laser is that as it cuts, it cauterizes. So the patient walks out with little to no bleeding at all. And the tissue looks a little charred at first, but it heals up beautifully. So here we have her pre-op picture, post-op picture, right? We've corrected that architecture, created more of a balance between the front 2 teeth. And now looking at this with you guys here, I'll call myself out. Maybe I should have been a little bit more aggressive on 7 and 8, kind of raised them up a little bit more. But hey, you can always go back and do a small revision, right? Something that we see with these gingivoplasties sometimes is as the patient heals, they may have a little bit of tissue shrinkage, right? And it's super minimal. Like we're talking like a 1/4 millimeter sometimes, but that 1/4 millimeter can like push you over the edge in the other direction, right? She didn't, so I should have gone a little bit further on 7 and 8 to make them really more symmetrical with 9 and 10, but she was stoked, right? And that's ultimately what matters.
I have a question
Yeah.
about the last slide. How does that affect the pockets? Would it affect it at all, or?
That is a great question, and I love that you asked that question. So we do this sometimes for management too, right? We'll gingivoplasty and decrease the depth of the pocket. So the same way that we use the laser for decontamination, right? Like if we put the laser straight into the pocket and turn it on, you're not going to just leave it there, right? But we're using it like a wand inside the pocket. We're decontaminating and removing some of that diseased, inflamed tissue. But if we angle it and kind of point it straight at the tooth here, and it starts cutting on its side, we can trim down the level of the pocket and go from a 6 millimeter pocket to a 4 millimeter pocket, right? And that's huge, 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 huge. Those 2 little millimeters, right? We go from red complex, from a completely anaerobic environment, now to a more aerobic environment where we have orange complex, right? It's still not great, right? It's still not green, but dude, like a heck of a lot better than red, right? So that is a phenomenal question, man. Thank you for asking that.
Thank you. Thank you.
Any other questions, guys?
I have a question about the tissue exposure from like different smile lines.
Yeah.
Does it affect, because your tissue is more exposed, kind of like what you said about masks, does it also affect like the oral health in your, like inside your mouth basically?
When, like from smiling?
Yeah, like if there's more or less tissue exposed, does it have any like effects in terms of your health?
I don't know. So probably not unless you're like smiling all the time. You know, because smiling is a fairly transient thing. You smile and your lip drops back down, so the saliva comes right back, right? You're not exposing the tissue and drying it out and all of that. So it's an interesting question. I'm not sure that I can answer it fully. I wouldn't suspect it would unless you were like perma smiling.
Thank you.
Yeah.
I have a question as well.
Yeah.
So for the patient that she had like her flossing and brushing transformed, that she had the high gum on the canines, would she be a good candidate for like growing the tissue at your place and then kind of sewing it on? And then
Gum grafts.
Gum graft, yeah.
Yeah. So gum grafts are really, really interesting. The best we can do with gum grafts is strengthen the tissue that's there. Let's go back to that. I think you guys, let's see where she at. There we go. Okay. So this amount of massive, she actually had gum grafts. And you can see how the tissue right here bulks out more than the tissue here. You guys can see that, right?
Yes.
So gum grafts are interesting because whereas when things develop, we develop that attachment layer where the gums are literally sort of like Velcroed onto the tooth. When you lose that, you don't really regain it. So if you were to cover this with gum tissue, all of this would be a pocket. Right? Because the gums doesn't really bond or reattach to the tooth predictably. That's a problem, right? So you end up with this massive pocket there, you know, and the gums start here, but she still probably has a 2-3 millimeter pocket, right? So if we slap on some gum tissue here, this is maybe, I don't know, I'll say that's about 4 millimeters, right? Tack that on, now you got a 7 millimeter pocket. Maybe not a good idea. So she has naturally what we call a very thin biotype. Not all gum tissue is created the same. Some people have, right, all of the gingiva, all of the tissue right around the teeth is like the palm of our hand, right? Nice, thick, dense tissue that can take a beating. Well, some people's is like the palm of your hand, and some people's is more like the back of your hand. And that tissue's frailer, it's more delicate, right? So depending on the constitution of the gum tissue that people have, they're going to be at a higher or lower risk for recession. And she had a very thin biotype, and she got a lot of recession. And then she got the gum graft done, and well, we didn't really protect the gum graft, right? You can see the gum graft right there. Right? So maybe when they grafted it, it was a little bit lower, and then we didn't take care of it, so the inflammation happened and the gums receded again. But generally, just slapping gum tissue over exposed roots doesn't fix the problem. Good question. All righty. So next week, talk a little bit about COVID and TMJ, how the two are interlinked and intertwined, and ultimately how stress kills smiles. All right, we break teeth, we wear them down, we don't sleep well, we have headaches. Stress sucks. Be happy in life, minimize stress. All right, guys. Any other questions? Oh, I wanted to show you guys this picture because it came into the practice not too long ago. So look at that. Look at that. This is tooth number 5. Check out that crack there. This is a 50, I want to say he's like 53 or 54 Hispanic male. Lifelong tooth abuser. Right, and came in to the practice a couple months ago with pain. She's like, man, I was eating something and she's got this really sharp pain on the top right. We take a look and just clear as day. He split the tooth right down the middle, all the way down. This is a bi-rooted tooth, and he literally separated the tooth in two. We'll revisit his case again when we do our tooth replacement lecture, because that was an immediate extraction and implant placement. Yeah, it was, I mean, I love to do it, so it was fun for me, but it sucked for him. And things like this are manageable, folks. And for instance, we can see this is tooth number 5. Let's take a look at tooth number 4. That guy's not too far behind, right? So it's our job to see things like this. And we had the conversation, all right? I'm not the I told you so type, but I told him so. We had the conversation that this at this point here, like we can prevent this from becoming this. All right, put a crown on the tooth, and now it can never split. You'll never have to have it removed out of your head. But he didn't listen, so now he has an implant and a crown. All right.
I have a quick question. How did you extract it if it was cracked? Did you
It's so much easier. So much easier
Yeah.
to extract. Yeah. So frequently, especially when we started getting into like implant dentistry and things like that, we want to remove teeth as atraumatically as possible, meaning disrupting the bone and the soft tissue around the tooth as little as we can to maximize how much bone is available for us to put our implant, right? So on multi-rooted teeth, so basically all of our back teeth that have multiple roots, what we'll do is we'll section the tooth and separate the roots and remove roots individually, right? Because it just becomes much easier and you can just sort of tease it out of the socket instead of like clamping onto it with a big forceps and ripping it out of the bone. So he actually kind of got the procedure started for us.
Hello, I have a question.
Oh, I see a dental chair in the backdrop there. That's cool. All right. Yeah, Haley, sorry.
Okay, so you stated that pink gums are normally healthy and stuff, but due to genetics, some people's gums are darker pigmentation wise. Is there a different way to go about telling the healthiness of the darker gums?
Great question. Yeah, absolutely. So not all healthy gums are pink, right? Now we do have, I personally have darker pigmented gums and they're healthy for the most part when I stick to my routine as well as I should. So what we use in situations like that, right, are all of the metrics, right? Pocket depth, bleeding index, right? Like what happens with the tissue when we measure it, right? Now, is there any evidence of infection there, right?
Thank
Good
you.
question. Thank you.
I have a question.
Yeah.
When you're measuring pocket depth to try to like, you know, begin diagnosing anything, how does that affected by like patients who have receding gums?
Wonderful question. So now we're getting into a deep dive here, folks. This is supposed to be like a 30,000 foot view, but I like the analytical minds here. So really, we start getting into what you're referring to something called clinical attachment loss, right? And so let's see. Let's go back here. Oh, I love that question. Dentistry is so much fun, right? So much to learn. Let's see. Okay. So let's take a look at this exact situation here, right? On the left side, we have health. On the right side, we have disease. Now, we also see on the left side, we have a 3 millimeter pocket. On the right side, we have a 5-ish, maybe almost 6 millimeter pocket. But the pocket height, the gum height is also different, right? The gums have already sort of come down here a little bit, right? Relative to this side here. So what we do, we'll say that this is recession of, I don't know, we'll say 2 millimeters of recession, 3 millimeters of recession. So ultimately, what we do is we add those two numbers together. So we'll measure the pocket, and we'll also measure how much the gum tissue has migrated from where it was originally, and add those two numbers together. And that's something called clinical attachment loss, right? Which is a more sophisticated metric than just pocket depth to assess the progression of gum disease.
And you
Great
would use the same numbers that we were talking about, like 1 through 3 and 5 and 8 for the different levels?
Yes. Yeah. So that aspect doesn't change, right? If you have 5 millimeters of recession and a 2 millimeter pocket, the environment there is aerobic, right? So you're probably going to have green complex bacteria there. And you get to a situation like that for a host of different factors, right? Bone anatomy can create big recession, right? In the absence of inflammation. Or the patient had a ton of inflammation that was addressed, right? That led to all of that bone destruction. And as the inflammation got better, the gums just sort of shrank, right? Making the recession more visible and the pocket shallower, right?
Thank
Great
you.
question. Yeah.
I have one more question.
Mhm.
So, for patients that don't really mind of their gum exposure while they're smiling, how would you recommend Botox or training the smile if they don't find the issue with
I wouldn't.
it? Okay,
Dude, all of this, like aesthetic beauty's in the eye of the beholder.
okay.
And the only person that has to feel good about their smile
It's the patient.
is the patient, right? You know, there are marks of distinction. Like some people love their midline gap, right? And that is like their trademark. And they own it and they have a beautiful smile. And it's not like if we deviate from those things, we can't have a beautiful smile, right? The number one thing for a pretty smile is confidence, right? If you like your smile and you flash it, it's going to come across as inviting and welcoming and attractive, right? But we all know that we have certain archetypes and standards of what the ideal, like common consensus of ideal smile is, right? And those were the things that I wanted to address with the lecture here. But if someone likes their high smile line and that's just their smile and they dig it, dude, you dig your smile. I always get this conversation started with patients in our comprehensive oral evaluation, like their first checkup visit, as we take a series of pictures on all of our patients, right? My assistants take x-rays, take pictures, we'll take a CT scan and an intraoral scan on our patients. And then doctor walks in, we start chatting, right? And doing the evaluation. I will pull up their big smile picture on the monitor in the operatory and ask them, if I gave you a magic wand, would you change anything? And then just listen. Some people are like, they have a super gummy smile, gaps between all of our teeth. Everything is gray from like taking antibiotics when they were a kid. And they were like, I love my smile. I'm like, dude, that's awesome. Do you? Right? So the patient is really the one that drives that conversation because it is entirely subjective.
Okay, I understand. Thank you.
Yeah.
I have a
Thank you for the
question
question.
jumping off of that.
Yeah.
Okay, not necessarily they like their gap or things like that. What if they go and then you're like, okay, if this is unhealthy, like we have to remove this. If not, what if they tell you no, like I don't want to change that about me? Because they, I don't know.
So
like
are we
let's say they like the amalgam look instead of like the new look. Like,
Okay.
would you be like, okay, no, because that's bad for you, I have to change it? Or would you be like, okay, that's your decision?
No, it's always the patient's decision, right? Like,
But at that point, you're like their doctor. So you're supposed to be like, okay,
I'm
this is
always
not
their
good
doctor.
for you. Yeah,
I'm
so you're
always
like,
their doctor.
but you're like,
But-
this is good for you, this is not good for you. It can lead to cracks and other things, but they're like this look, I guess you can say.
Sure. I mean, it's our responsibility to inform and educate, right? And give patients the information they need to make a sound decision. But it's always their decision, right? I am not a serial amalgam remover. Like, I do not believe that just because you have silver fillings, you're going to be unhealthy, right? right? So just sort of going along with your topic of conversation there.
Yeah.
So I don't recommend across the board removal of silver fillings if the silver filling appears to be healthy and isn't doing damage to the tooth. If it is doing damage to the tooth, it's my responsibility to bring that to the patient's attention. And then it's their responsibility to determine if they want to do something or not. And we have to respect that, right?
And if they decide like, no, how would you go about that? Like, okay, go on with your day, and when your tooth cracks, they come back to you and then you fix it?
As opposed to what? Strapping them in the chair and doing the crown? Yeah.
Yeah,
What
but
are you going to do?
so there you have like no say. You're kind of like, okay, it is what it is.
I really, yeah, I don't know.
I'm sure you've never, I don't think you've been in that like position where, because I'm sure people go to the dentist because they want to get the things fixed. But I'm just going off of like,
sometimes they just want to go for a checkup and they don't think anything's wrong. And you see a big crack in a tooth and you show them, right? Like the case we were talking about with the cracked tooth. We had the conversation. Hey, I see these cracks in your tooth. If we put crowns on them, they won't break and you won't have to have it pulled. Okay, I'll think about it. Never wanted to do anything, came in for his next hygiene visit. Hey man, cracks are still there. They don't look good. That can break. Well, take my chances, been that way forever. Okay. Comes in one day, tooth broke. What else are you going to do? And you're not going to do something against someone's will, right? You just educate, inform, and document, right? You document that you had the conversation with the patient, that you recommended what you did, right? Because anytime that we see a patient, there is a legal responsibility component to everything, right? And if we diagnose something, if we diagnose a crack and we tell the patient, we just write it in our chart, patient informed, crack, likelihood of fracture, potential need for tooth removal, had the conversation, patient refused treatment. Okay. It's always their choice.
oh, okay, thank you.
Yeah. Thanks for the question.
It's like one time I went shadowing and the patient said, can you only do the tooth that's the worst? And then the doctor did the tooth that was the worst, and then they didn't want to do like the other. They're like, leave the other 2 teeth for next time.
Yeah, and that happens sometimes, guys. I mean, as much as we want to advocate comprehensive total dentistry, like sometimes that's not the best thing for the patient. Sometimes it's a financial issue, right? They can't afford it. Sometimes it's an intolerance of just being in the chair, right? Like they can't have a prolonged visit, like all sorts of different things. Like there is no one answer, right, for all of our patients. That's why, like we talked about last week, like we have to educate ourselves and have as many tools in our toolbox as possible to tailor treatment for our different patients, because everyone's different, guys, and every mouth is different, and everyone's personal circumstances and situation varies, right? And all of those things together is what ultimately dictates the treatment that we do and how we can help people. But yeah, you'll find people who just, they know that there's a problem, but they have an ostrich mentality. They just want to bury their head in the sand. And what are you going to do?
Hey, doctor, I have a question.
Yeah.
Does the recession always mean that there's an infection?
No.
Okay.
No. So recession happens from different factors. Sometimes they're local anatomical factors. Things like crowding can lead to recession because the tooth is literally like displaced in a direction that has a tendency to push the gums down. Things like brushing too hard can lead to recession. We can literally do trauma to our gums if we go ham on the toothbrush. So frequently people will hold a toothbrush like they're holding a hammer, right? And that way they can really sort of get their bicep into it and like really brush things clean. Yeah, that is way too much pressure, right? I'm going to, right, you guys can see me now?
Yeah.
So you literally need to hold your toothbrush. I don't even have a pen around here. It's terrible. All right, so we'll use Blistex instead. So sometimes people like hold the toothbrush like this and like really, if you hold your toothbrush back here at the very back of the tip, right, and brush that way, that's how much pressure you should be using to brush. All right, so it's very, very light pressure, always using soft bristles, right? Never medium or hard, light pressure. So force, anatomy, and infection can all create recession.
Thank you.
Dr. Alex, thank you so much for this session. It was very, very informative and at times pretty funny as well. But thank you so much for your time again.
Absolutely, guys.
Everyone who stayed to the end, you guys are the best.
All right, so
yeah, I guess we are. Everybody.
Yeah, we are. Session 3 is not next week; it's 2 weeks from now. So 2 Fridays.
It's the week after.
Yep.
Yeah.
Thank you.
Awesome, y'all. Have a great Friday.
Thank you.
I have a question.
Oh, we have another
Okay, I
question.
wanted to ask you. Yeah, I
Hi,
have a question.
the dental chair.
I wanted to ask you, what's your protocol? Yeah. Yeah, I've been working front desk for 2 years at a dental office. But I wanted to ask you, like, what is your protocol when it comes to certain patients that don't want to do their annual periodic and the bite wings? Like, what do you do about that?
I don't think we have enough time.
When they refuse, because I know, like, and they just want a cleaning.
Yeah, I just want a cleaning conversation. That is, like, overcoming patient objections, Yanetsi, is like a full day worth of conversation and lectures and scenarios. And again, people don't refuse things for the same reason, right? So we need to meet people where they are and see what their objections are and see what their hesitancy is and see how we can navigate those things. You know, a lot of that is prevented by educating our patients beforehand, right? The more informed people are, the more they know that you have their best interest in mind, the less we have to have those conversations. Right? So it's a great question, but it's kind of a loaded one.
Awesome.
All
Take care,
right.
everybody.
Bye.